Hello, Martin Perez.
area of EGFR mutations is that approximately 25 to 35% of the patients receiving first-generation EGFR TKIs do not receive second-line treatment. So I think probably, in my opinion, in general, not only in the EGFR mutation status, I think we need to give the most potent combination or agent upfront. In patients treated with osimertinib, we have learned that the mechanisms of acquired resistance included MET amplification and also secondary EGFR mutations, mainly the C797S, and there is a biological rationale to give amivantamab plus lazertinib. Lazertinib is a third-generation EGFR TKI, similar of osimertinib, and amivantamab is a bispecific that targets both EGFR and c-MET. So the mechanism of action of the combination of amivantamab plus lazertinib included that there is an extra and intracellular binding to EGFR by amivantamab that binds in the extracellular domain and lazertinib in the intracellular domain, and also amivantamab binds also MET, that is a mechanism of acquired resistance. And there are some studies showing also that the amivantamab is associated with an immune-mediated activity. So again, the design of the Mariposa trial is very well known. This was presented by first time during the ESMO meeting in Spain. In this trial, patients with sensitizing EGFR mutations were randomized to receive the amivantamab plus lazertinib arm versus osimertinib versus lazertinib in a randomization of 2 to 2 to 1. The osimertinib and lazertinib part were blinded for the investigators and also the patients, and the lazertinib arm included only 216 patients because the reason of this arm was to assess the contribution of components by FDA. So in this study, the primary endpoint was progression-free survival, comparing AMI plus laser versus osimertinib. Importantly, in the trial, there was a clear analysis of what happened in the brain. So in all the patients, baseline brain MRI was required prior to randomization, and also for the patients without brain metastases, brain scans were scanned. So in this trial, the patient's characteristics were the usual: Asian patients 60%, smokers 30%, and the percentage of patients with brain metastases here and in FLAURA2 is relevant. 40% of the patients had brain metastases at the study entry, and 60% of the patients had exon 19 deletion. And the first, perhaps, point is that lazertinib was compared to osimertinib, and both treatment arms were comparable in efficacy and safety. Again, this is the primary endpoint. Progression-free survival was longer with AMI plus laser when compared to osimertinib. Again, you can see the median PFS with osimertinib alone, 16.6 months. The hazard ratio favoring AMI plus laser was 0.70. Here the toxicity. So with AMI plus laser, we saw paronychia, grade 3 in 12% of the patients, rash grade 3 in 17% of the patients. It was also another toxicity that it's important to discuss is the infusion-related reaction that occurs mainly in the first administration, and this happened in 65% of the patients. And also, in this study, it was seen that there were some VTEs, vascular thromboembolism, that occurs, and it was mandated after to see these toxic adverse events to start with anticoagulation. So the next step, and here I'm discussing briefly safety, is that some studies have shown us how to reduce toxicity. So prophylactic anticoagulation was implemented in all patients started AMI plus laser. Anticoagulation should be done for 4 months, and in the analysis for those patients without prophylactic anticoagulation, 20% of the patients had VTEs. For the patients receiving prophylactic coagulation, the percentage of patients with a VTE was 11%. That was very similar to what we have seen in the osimertinib arm. Then the skipper started to show us the pre-medication. In this analysis, dexamethasone was given 8 milligrams twice, the day -2, the day -1, and 1 hour before the infusion. And with this schedule of the dexamethasone, the infusion-related reaction occurred in the first cycle in 22% of the cases and in 67% of the patients with a standard infusion-related reaction -. And finally, the CUCUR with some dermatological preventive actions, and again, with this strategy, the percentage of patients with grade 2 or higher dermatologic adverse events clearly decrease when compared with those patients without these preventive actions. So we have learned that when we start treatment with AMI plus laser, we should give dexamethasone as a preventive schedule before the first cycle. Also, prophylactic anticoagulation during 4 months, and then the dermatologic recommendations with doxycycline for the weeks 1 to 12, and also nail cleaning agent, and also long-acting skin irrigation. And with this, the toxicity clearly decreased. The next step was to analyze which patients may benefit from the combination therapy. And this was analyzed in the FLOWER2 trial, and for example, for those patients with brain metastases, the median PFS with osimertinib was 13.8 months. With those patients without brain metastases, it was 24.9 months. One difference of FLOWER2 when compared to MARIPOSA is that for those patients without brain metastases at baseline, there was no requirement of further CNS images in the follow-up of the patients. So also you can see that for those patients with a P53 mutation, the median PFS was also similar, and also for those patients with plasma EGFR undetectable, no clear differences. In MARIPOSA, in which there was an analysis of brain in all the cases, patients with brain metastases and patients without brain metastases, it was presented and published in the New England Journal of Medicine that the hazard ratio for PFS was exactly the same. For those patients with brain metastases, there was a clear improvement with AMI plus laser when compared to osimertinib with a hazard ratio of 0.69, but also for those patients without history of brain metastases, in which the hazard ratio was exactly the same. Here, the key outcomes from Mariposa across groups. We have discussed the brain metastases. Perhaps to mention that for those patients without p53 co-mutation, the hazard ratio favoring AMI plus laser was 0.75. For those patients with p53 co-mutations, it was 0.65. And perhaps analysis is that for those patients without EGFR mutation clearance after week 9, so these are patients with positive EGFR mutation at baseline, it was repeat the analysis at 9 weeks, and for those patients without clearance, AMI plus laser was associated with longer PFS. But also, for those patients with clearance, it was also the same. But for those patients without clearance, you can see here a hazard ratio of 0.49 following AMI plus laser. Activity in CNS in Mariposa was updated in the LCC by Dr. Yang, and with longer follow-up, we can see that the intracranial progression-free survival in patients with baseline CNS metastases was longer with AMI plus laser when compared to osimertinib, and perhaps it's important that at 3 years you can see that the difference may increase when compared to previous analysis. And also the intracranial duration of response for those patients with baseline CNS metastases was longer with AMI plus laser when compared to osimertinib alone. So, and then overall survival. Should the overall survival be the most important relevant endpoint we can discuss? I think it's important to be able to increase the survival of the patients with lung cancer. And yes, these two trials, FLAURA, FLAURA2, and Mariposa, are positive for overall survival. I will not discuss osimertinib alone arm. In all the trials is exactly the same. Is associated with a median survival of around 36, 38 months. So I think it's important the improvement in overall survival. In the FLAURA2, you can see the overall survival was 47.5 months versus 37.6 months with a hazard ratio of 0.77. In the Mariposa trial, the median overall survival was not reached, and it was 36.7 months in the control arm. And this is the curve of the FLAURA2, the overall survival results. And also, I think it's important again that in the Mariposa trial, and you can see here the overall survival presented, it seems that there is a separation of the curves with a longer follow-up. So I think we need also to follow this survival that is relevant. We mentioned the hazard ratio of 0.75, and again, at the clinical cutoff date, 38% of the participants in the AMI plus laser arm were still receiving the treatment. The overall survival subgroups, and perhaps this is another topic that we can discuss. Can local consolidation therapy extend survival in patients with EGFR mutations? We don't have a clear recommendation, but at this year at ESMO meeting, there was a study presented in which a patient received induction osimertinib, and then for those patients without progression, were randomized to receive osimertinib or osimertinib plus local therapy, and this is something that we need to evaluate in the future, that progression-free survival was longer for those patients receiving longer treatment. I think it's important to discuss the mechanisms of acquired resistance in both trials. In the FLAURA2, this was analyzed using ctDNA analysis, and there was no clear differences in the mechanisms of resistance for those patients receiving chemo plus osimertinib or osimertinib alone. The most frequent mechanisms of resistance were the EGFR secondary mutations, the C797S, and also MET amplifications in both treatment arms. I think it's important to say that in the Mariposa trial, there was a reduction of MET amplification as a mechanism of resistance for those patients receiving AMI plus laser, and there was also a reduction of the secondary EGFR resistance mutations for those patients receiving AMI plus laser as a mechanism of resistance. And I think for me this is important to discuss because probably it's related to the biological activity of amivantamab. And then a few words about amivantamab subcutaneous formulation. There was Paloma 3 that was presented by Natasha Leif and also published comparing subcutaneous AMI plus laser versus IV AMI plus laser. The primary objective of this trial was co-primary PK endpoints. It was a study of non-inferiority PK endpoints for subcutaneous when compared to IV. This was met, so sub-Q amivantamab was non-inferior to IV. And I think probably the most important point is that the median administration time for the first infusion was reduced to 4.8 minutes for subcutaneous administration compared to the 5 hours for IV amivantamab. And the infusion-related reactions were different. The percentage with the IV AMI plus laser, 66% of the patients had infusion-related reactions. With the sub-Q, only 13% of the patients. And also the rates of VTEs, when compared all the patients, VTEs were seen in 14% of the cases treated with IV, in 9% of the patients treated with sub-Q. And when we analyze those patients with prophylactic anticoagulation, VTEs were seen only in 7% of the cases treated with sub-Q amivantamab. There is a paper showing that the subcutaneous amivantamab administration simplifies and shortens administration and also reduces resource utilization, and importantly was the preferred option for patients who receive AMI plus laser. So my conclusion about the AMI plus laser combination is that it's a chemotherapy-free regimen. Probably if we use the subcutaneous formulation, is also an IV-free regimen and show longer PFS and overall survival versus osimertinib. There is a need for proactive prophylactic approaches, including the management or prevention of infusion-related reactions, VTEs, and dermatologic adverse events. I think if available, subcutaneous formulation is preferred when compared to AMI, and we can also discuss that it's important that the mechanisms of acquired resistance with this combination is associated with lower incidences of MET and EGFR secondary mutations. And I think this is the summary that, I would like to share with you all. Thank you.
Thank you. That was an awesome overview of the two most important studies as changed the landscape of the way that we approach patients in the first-line setting. I'm just going to share with you my slides because we're going to now. Can you see the slides?
Yeah.
All right. So how do I make this bigger? So we're going to I mean, we've got such fantastic faculty, both regionally, locally, and yourself, that we wanted to be able to ask those important questions. Just putting up a few slides, looking at the unmet needs of those patients in the first line setting with who have an EGFR mutation positive disease, and really looking at the fact that you have different types of EGFR mutations. We know that giving first line EGFR TKI alone, progression is actually relatively fast. It's usually occurs within 10 to 19 months, and a lot of these patients don't even actually get to the second line setting. And if you look in the real world setting, a lot of these patients have at least one high risk feature, including being of older age, having the EGFR L858R mutation, brain metastases, liver metastases, having ctDNA positive disease, and of course, that thing that we don't always like, which is the TP53 mutation. And here you see that despite the advances in the EGFR TKI monotherapy around these patients, each year you're seeing a rapid drop-off when you're using first-line setting. So my question to you is that since we have now
to be honest, like this is honestly what I've been doing. So I would say like the last year or a year and a half or so, because we know with all of these data, whether in the overall survival or in the event-free survival, the combination strategy is the way to go, not only for those patients with adverse prognostic factors, as you just showed us, Shahina, but also, combination strategy, this will delay resistance, this will hit the cancer hard, this will also allow, the objective response rate to be better, and especially with those patients with, let's say, high burden disease, liver metastases, brain metastases. The other thing is like also, as Dr. Enriqueta just beautifully showed in her slides, we know that there is about go further into details to let people have some people also talk. I would only offer monotherapy for like elderly patients who actually are in a clinically, let's say, bad shape, but otherwise combination is the way to go.
Enriqueta, what if you had a patient right now, she's 40 years old, she's a young lady, she's a working woman, and she presented with stage 4 de novo non-small cell lung cancer. She's got an EGFR mutation. She does not have brain metastases. Her molecular profiling is fantastic, no adverse biomarkers, and the only reason she has stage 4 disease is she's got a couple of biopsy-proven bone metastases. Her single agent osimertinib or combination?
I think in general, I think combination is a standard of care for patients with mutations the first line. Now, for a patient with 40 year old, and also for a patient with 65 or 70, I would agree that if I have a patient of 85, 90, so it is a slightly different situation, and yes, but in general, I think combination. So we have trials showing an improvement in survival, and I have to say that in this disease, the median survival with osimertinib is 31, 32 months in patients with a good performance status that are patients included in clinical trials. So I think combination is the next step. We have seen a very important improvement in overall survival. So we are not discussing 1 or 2 months improvement. So I think the magnitude is clearly relevant. Of course, we need to discuss the toxicity, give all the options to the patients. But in general, I think in my experience after discussing this with the patients in general, yes, I agree with combination. It's our obligation to manage the adverse events. So this is the reality.
I'm coming to that.
Sorry.
All right, Hassan, post-progression, is it important to repeat NGS and why? Very quickly, because we have a lot of
Yes,
questions.
definitely. We want to know what the resistance mechanisms are, and if we still have a target that we can, use. So I think I would want to repeat it most patients.
Dalia, do you have any long-term survivors on single-agent osimertinib? I mean, if so, what are their characteristics?
Actually, they are there. The ladies, the young patients, Asian, mainly Asian background, with minimal disease. I have many like this on single agent also. Yes.
Okay, so that makes us wonder. The thing is, we don't have any biomarkers. Enrique, do you agree that we just simply don't have the biomarkers to pick and select who should be receiving single agent versus combination? I think that is the problem that we're facing, because if we did have the biomarkers, because there are certainly some patients who are on single agent osimertinib for years, but it's a small minority, I agree. But there are those specific patients, correct?
Yeah, and there is specific patients, but we have two randomized trials showing that the long-term survivors are so at the end we all when we think the patients, we all think in the patients that are doing pretty well. I think I have one patient that still is receiving erlotinib, so this is but at the end, the reality is that here we have two randomized trials that is not a perspective and without the methodology.
So we've got two trials, as Enrique says, FLORA-2 and Mariposa, and she's already gone through the differences in these two trials. I specifically wanted to focus on the fact that there was a difference in actually monitoring of brain metastases between FLORA-2 and Mariposa-2. Mariposa. So in the FLORA-2, you had 12 scheduled scans for patients with a history of brain metastases at baseline, and only one scheduled scan for patients without a history. While in Mariposa, they had 16 scheduled scans for patients with a history of brain metastases, with 6 scheduled scans for patients without brain metastases. And for me, when I look at that difference, it seems to me that in Mariposa, you're more likely to pick up the brain metastases if you're going to monitor them so closely. So, Hassan, do you think that the brain monitoring protocol differences between the two trials actually impacted the results that were shown subsequently?
Yeah, I mean, certainly if you're monitoring pre-scheduled scans, you're going to pick them up early, so your CNS PFS
is going to be different, right?
Yeah, it will be different. It will be more accurate in the Mariposa, but in the FLORA-2, you may miss you may have a longer PFS just because you didn't do the scans. So yes, I think that could be a contributing factor. However, I think I would also say that, in our usual practice, we don't tend to do too many MRI brains unless there are symptoms or they were, had brain mets at baseline. So I think for a trial purpose, I want to go with the Mariposa approach, but FLORA-2 also sometimes reflect what we do and end up doing in the practice.
So when you look at the subgroup analysis of FLORA-2, you see that the biggest benefit in terms of that PFS is actually in the CNS group of patients versus the non-CNS group of patients. So Enrique, how do you explain, because when the study results were first presented, forget the overall survival, when it was first presented, the main benefit was actually those patients with the brain metastases. So how do you explain that?
Yeah, I don't have a clear explanation. So I think, at the end, the FLORA-2 has the results, but even for me, it's difficult to understand biologically the contribution of chemotherapy in this situation. So, I am not able to clearly understand. I think it's important what you just mentioned. So the follow-up of the brain is clearly different in the two trials. So
Yeah.
it's true that in the two trials, the percentage of patients with brain metastasis at baseline is similar, is 40%, but the reality is that the follow-up for those patients without brain metastasis is clearly different. And this, if we are not doing the brain MRI in the follow-up, it's difficult to assess the progression. And this happened also in the patients at baseline. I remember that perhaps 1 or 2 years ago, or if the patients are not in a clinical trials, we don't have always brain MRI. And in the clinical trials, when we are performing brain MRI, we are able to detect some asymptomatic brain metastasis. So I think the most important is the follow-up of the patients with brain images in these trials.
Could it be the Alimta component of it that was helping with the brain metastases? Because we know that Alimta does do something in the brain for some of these patients. I'm just putting it out there. Abdul Aziz, you got your hand up.
I was actually wanted to comment about probably from the gain that the patients got from Mariposa is probably the synergistic EGFR inactivation, right? So we have two agents against EGFR, the TKI and the bispecific antibody. So this would be would be one of the theories. The other thing is that possibly also the immune-mediated effect from amivantamab, from the bispecific antibody perspective, and this is what I guess led to have Mariposa as one of the preferred regimen in NCCN and multiple other guidelines to be used as one of the first line options for CNS disease. I mean, in EGFR mutated lung cancer.
So now let's look at the overall survival. You can see from FLAURA2 there was an improvement in the overall survival. And then of course Enrique also already talked to us about the differences in the resistance mechanisms, which is actually weirdly almost the same with chemo plus Aussie versus Aussie alone. So Dalia, were you surprised that there were no differences in the resistant mechanisms between the two groups, despite the fact that we got an overall survival advantage?
You mean between the Aussie and the FLAURA2?
Between Aussie and Aussie plus chemotherapy.
I think, it's expected because by the end we are giving the same TKI which is targeting the same EGFR, and we are giving together with chemotherapy. So the driver mutation, this is the one who is going to be affected by the TKI that we are giving, and whatever resistance is going to be happen, it will be against the TKI that we are using against the specific EGFR mutation. So I don't think there will be any effect on the type of resistance based on chemo and TKI.
Enrique, weren't you surprised? Because ultimately there was an overall survival advantage. So inherently you would think that those patients who are getting Aussie plus chemo may not have such bad biology of disease because you're giving a combination and that resistance mechanism is not as bad, which is what we saw in Mariposa.
Yeah, I think I'm not surprised that in patients treated with chemo plus osimertinib or osimertinib, there was no difference in the mechanism of acquired resistance due to the mechanism of action of chemotherapy. So I am not surprised of that. Sometimes, as I mentioned, I need to better perhaps understand biologically the contribution of chemotherapy in these patients. So yeah, perhaps yeah.
Okay.
I have a comment here if you allow me.
Yes, because we have 15 minutes.
Just quickly, I think the type of resistance is different between the two trial regime, between the Mariposa and between the FLAURA2.
I'm coming to Mariposa. The resistant mechanism of Mariposa, I'm coming to that. Before we jump into Mariposa, since Dalia wants to talk, I love it. Have you used FLAURA2?
Yes.
And what sort of side effects have you seen with FLAURA2? Typical side effects in the clinic.
As we experience with chemotherapy, this chemotherapy, this is the main side effect. Also, you can in the maintenance phase with Alimta, we have patients with renal impairment developing during
Hassan, have you used Flora-2?
Yeah, so I think.
And how long are you giving the chemotherapy portion of Flora-2 for?
Well, I like to push it as long as I can if the patient can tolerate. Dr. Philippe showed us that patients who took it for 18 months were the ones who are actually benefiting from that OS. So the goal is to push it not to just use a short-term chemo and say, oh, we did the combination.
But Enrique, this is exactly what's happening. Osimertinib on its own, and looking at the data that you have actually presented, and we've also seen the exposure in Dubai, in Europe as well. This is what they're doing. So what are your thoughts on that?
The study clearly states that the patient received cabo or cisplatin plus pemetrexed 4 cycles and then pemetrexed maintenance. So I think the study is not designed to answer this question. I think 4 cycles of chemo plus pemetrexed only, is not what happened in the clinical trial, and we are discussing here overall survival results.
Exactly. But then David actually presented this data at the WCLC, showing that the median exposure to pemetrexed was only 8.3 months, and despite that, there was an overall survival advantage. So Abdulaziz, how do you explain this?
Well, I mean, possibly again another synergistic effect with chemo and Tagrisso, but the thing as I just wanted to add also, I have a good number of my patients since I've been using the combination strategy. I would say 6 to 8 cycles are the average for those patients until they get fatigue or start to have myelosuppression. But minority of patients actually go beyond that. So this is something that we always have to keep in mind just to look at the toxicity profile of chemo plus Tagrisso.
Okay, so let's shift gears to the Mariposa study. Enrique has already presented the study design and the monitoring for the brain metastases. Now, when you're looking at the PFS of osimertinib plus versus lazertinib, you see practically no difference. So Enrique, can you tell me if, this is what's happening in the community, that's why I'm asking this question. Is osimertinib and lazertinib interchangeable?
I think what the Mariposa trial show us is that the results are very similar with osimertinib, PFS, and also no major differences in toxicity. But I think I am not comfortable to give AMI as AMI plus osimertinib. I think the trial that we presented, the Mariposa, give AMI plus lazertinib. So this is my election. So again, it's the same of the chemotherapy, 4 cycles or not. I think we need to follow what happened in the pivotal trial. So in this trial, the improvement in overall survival is with AMI plus laser, not AMI plus
osimertinib. And that's why we shouldn't just be going off and doing what we want in the community. We should be following the clinical trials. You presented the PFS. PFS was nicely improved with AMI plus lazertinib versus osimertinib. And again, we're seeing that overall survival advantage. Now, one of the things that maybe I missed it when you were talking, if you see both the studies, in that beginning portion of the Kaplan-Meier curves for the overall survival, you see a crossover. So, Enrique, how do you explain that? Both trials, beginning portion, overall survival, you see that crossover of the Kaplan-Meier curves. How do you explain this?
I think we have seen a group, an initial crossover, but I think it's not really relevant, at least from a statistical point of view. So I don't know if my colleagues have.
Hassan, what are your thoughts here?
Yeah, I have no idea, clinically, what was happening.
It's just that in both the studies, the same
Yes.
thing happened. And so I was asking the question, why was this happening? But irrespective, when you're in the clinic and you have to see a patient with an EGFR mutation that's positive in that first line setting, how do you pick and choose whether you're going to use FLAURA2 versus Mariposa, assuming everything is free, everything is available? How do you pick and choose?
It's that I have to admit that perhaps for me, it's clear that I need to discuss to do that. It's that for me, the biological rationale of the combination that is a chemotherapy-free regimen, AMI plus laser, and also the mechanism of resistance results are important. So this is my yes. So this is what I am thinking. At the end, we decided to change to osimertinib first line 6 or 7 years ago because osimertinib was also a T79M inhibitor that was the mechanism of resistance in 60% of the patients receiving GEFI plus or gefitinib or erlotinib. Now it's the same. So probably we are treating these patients with a mechanism of resistance, and I think it's important. So this is yes, I discussed with the patients, but yeah, I think for me the combination of AMI plus laser has a clearly an attractive rationale, a biological rationale to live in a patient with the EGFR mutations that we are treating.
So I'm actually quite fascinated with this, and we have a couple of minutes, and I wanted to just focus on that, and I'm going to skip over the brain question and really look at that resistance mechanism. So I'm going to ask you all this the same question here. I have a patient in the clinic right now that's 55 years old. She's a woman who presented with shortness of breath, pleural effusion, stage 4 de novo adenocarcinoma. She's got an EGFR mutation. The tumor was sent for profiling. She's got an RB1, a TP53, and a MET. I have both choices of therapy sitting in front of me in the clinic. I can give her AMI plus azartinib, or I can give her chemo plus osimertinib. Dalia, what are you going to give her? What would be your preference in terms of giving the treatment to her? Because people in our part of the world, they actually defer to us. The patients defer to us and they say, okay, you've told me the pros and cons of each, but what would you give? What would your preference be?
So your patient is 50 years, EGFR and EGFR mutant and MET mutant, correct?
So she's got a MET, she's got an RB1, she's got a TP53.
And EGFR.
Yeah, that's why I'm talking about it. That's why I'm talking
I
about
will
it.
Honestly, yeah, I will go with the dual regime. I will choose Mariposa. Why? Because the amivantamab, we know that it's a dual blockade. It is attacking or inhibiting the EGFR, and also it is also against the MET fusion, as I guess. So this will be priority. And actually, I have a similar patient, but without EGFR. She's a lady, a young lady, and she's ERB2 mutation positive. So doesn't have any other mutation. So maybe we can discuss this if we have time later.
Later, yes.
Be my choice.
So Hassan, have you given the combination of amivantamab plus lazertinib? So
Yes, I have.
and what is your experience been?
Yeah, so I have more experience in the second line with amivantamab, but I have a patient with the first line. So for your case, I think, definitely incline with AMI laser because, it has CMET mutation or amplification, and, I don't trust osimertinib working in that case. So I would choose the bispecific and a different TKI. But I think in generally, it's a difficult question how you select. But I think if you look at the curves, I feel that, and this could be a little biased, but I feel there is more durability of the responses in the OS with the ME laser compared to FLORA 2. And again, this is a subtle difference probably. But that's one. And then I feel that this is, the side effects can be managed. I think there's a learning curve to it. But
It's a
once
huge
after
learning
that,
curve,
I
but
think
it's
patients-
manageable. Yes.
Yeah, so
So-
patients, yeah.
Enrique, but why are people scared to use AMI plus Lazartinib? I'm just going to pose a question to the person who's used it the most. So, why are people scared to use it? Why is there such resistance to using it?
Yeah. I think probably, the infusion-related reactions they have an impact. But I have to say that it's really important to highlight that these reactions are clearly predictable. So only occur during the first administration. And
Exactly.
so it's important to give the dexamethasone prophylactic script regimen. So yeah, probably this was at the beginning, no? Because the dermatologic adverse events, I think we are more yes, able to manage. Probably it was the infusion-related reaction, but again, I think it's important. And now, for example, I remember that in the first administrations with the nurses in the day hospital, we have decided to give the administration always in the morning, okay? Because all the people are there. But then also the nurses are very comfortable because they know everything. So they know when will happen. The percentage of patients with these reactions has clearly decreased with the use of dexamethasone 2 days before, and so probably is this what
So,
happens.
Enrique, can I ask you the question? The other fear that physicians have here is the skin reactions that you get. Are you using all the prophylactic measures, including getting your dermatologist on board and using those antibiotics? And how has been your experience with the skin reactions? Because I have a number of patients with AMI plus Lazartinib, and I find that if you just use the prophylactic regimens as per protocol from the Cocoon trial, it's something that's actually quite manageable. So what are your thoughts here?
Yes, the same. So yes, we use the Cocoon strategies, and with these strategies, I think we also don't need to send the patients to the dermatologist in the vast
I
majority.
like to send my patients to the dermatologist, but yes, go ahead.
Okay, so this is the reality. In fact, I would like to highlight that we participated in our center to the Cocoon trial. In the
Okay.
Cocoon trial, there was the randomization between the prophylactic measures and also your standard of care. And I have to say that even in the Cocoon, when started, in my institution, the standard of care was also to give prophylaxis. This is the reality we have implemented. So yeah, I think it's a good way to prevent this toxicity. Yeah.
So Abdulaziz, you have the last word since we have only a minute and a half.
I just want to say, don't forget there is a subcut formulation of amivantamab that is hopefully coming soon. And today, actually, we have a recent, like a fresh publication. So we have previously Paloma 3 to look at subcut versus IV. We have Paloma 2, and now there's a Paloma 1B trial showing that it's also, it cuts down the side effects, whether the toxicity, dermatological, as well as infusion-related reaction. Also, it's given within less than 10 minutes without the use of, without the need to divide the first dose. So this is
Let
something
me
that
ask
we can apply very soon.
let me ask quickly in the last couple of seconds. Subcut is coming. Enrique, with your experience, do you think subcut, I know that it reduces the infusion-related reactions, will it reduce the skin-related reactions? Because I can't seem to think why it would reduce the skin-related reactions. You have 30 seconds.
Yes, I have to say that this is not clearly shown. So
Okay.
to see if it's also reducing, but I think what is reducing the rash and the dermatologic reactions are the Cocoon strategy.
Yes, absolutely. Abdulaziz, how often have you used Lazartinib AMI in your practice?
We just started one last week, but otherwise we have a lot of Mariposa too, because we just had the Lazertinib in our pharmacy about a month ago. So
Perfect. So the next time we do this roundtable, the next time we do this roundtable, you are going to tell us your experience with using AMI and Lizartanib. So thank you all. I've learned a lot. Enrique, your presentation was fantastic. Your sharing of your personal experience with using AMI Lizartanib has been fantastic. All I'm going to say is first line EGFR, it's no longer acceptable unless a patient isn't able to get combination. They should all be getting combination therapy, whether chemo plus Aussie or AMI plus Lizartanib. There are definitely differences between the two trials, but both trials show survival advantage. You need to discuss both trials with your patients because there are pros and cons to using both strategies. But in that patient that's got the most complex resistance mechanisms, in those patients that come up like my patient, the MET, the RB1, the TP53, my preference is to probably use Amiglizartinib versus Aussie chemo. And I'm just going to sign off with that and say that I hope to see you all in the next edition of the EIOC Journal Club. So thank you very much.
Thank you.
Thank you. Thank you. Take care. Bye.
Thank you.
Bye.
Thank you.
you.